So we'll start first, this one over here. So going through these, this one on the left, this is a epidural hematoma with midline shift. Someone threw midline shift out there, claw, and I saw someone else put that as well. Yeah, this is that biconvex lenticular that obeys suture lines. And remember, your suture lines are what's connecting your scalp onto your head. So it compartmentalizes it. So like that's why the blood fills that little compartment and it can't cross over so easily. So yeah, lenticular shaped biconvex epidural hematoma. What artery and then what anatomical area is on the skull is overlying the artery? Excellent. I see MMA, pterion. Excellent. So we'll move on to the second one. What do you guys think the second one is? I know a lot of you have said it already. And if you've said it already, what is your presenting sign or symptom of this? Actually admitted one of these 3 hours ago. Exactly. Worst headache of my life. Thunderclap headache. Excellent. Thunderclap headache. Now, when you guys and gals get to the floors, I have learned that the worst headache of my life is an awful question because everybody's having the worst headache of their life all the time, and they can't all possibly be having subarachnoids. So that'd be bad. So a lot of times what you have to ask them is that thunderclap sort of thing. Is it maximal intensity within a minute or so? That's your thunderclap. If it's bad and it got worse an hour later and now it's really annoying, no, that's probably not a thunderclap headache. You know, you want maximal intensity, short onset. I see Matthew throw in sumatriptan for your acute treatment, beta blockers. I see topiramate or Topamax a lot for migraines. What do you guys give this? So you're gonna call neurosurgery, and then you're gonna give one medication to prevent an important sequela. Unfortunately, yeah, okay. I see some people got it. It's not quite an easy question to not give it away, but nimodipine. No, it's actually, so I see a bunch of people coiled stenting. Man, someone's been reading. That is correct. But yeah, nimodipine is a calcium channel blocker that is associated with decreased vasospasm. The blood itself is thought to be irritating and may actually cause vasospasm and an ischemic stroke that comes after. On the right here is a subdural hematoma. It is a nice big crescent roll. This comes with midline shift. This is going to call your friends at neurosurgery and they're going to do a craniotomy. Burr hole you could also do, although craniotomy is better than a burr hole. So yeah, subarachnoid hemorrhage, we talked about this. A worst headache of your life, rupture of an aneurysm, give nimodipine to prevent vasospasm. Epidural, middle meningeal, over the pterion. Classically, it's called talk and die syndrome. A lot of times I will see questions based around like a baseball game. Somebody gets hit in the side of the head by a foul ball, or like you see with pitchers sometimes. They throw a pitch and they get hit in the temple on the side of the head. They go down, they get back up. They're at very high risk for epidural hematoma. And lastly, your subdural hematoma, your bridging veins. For those who are more elderly, who have like cerebral atrophy, they actually tend to do better sometimes because the blood can layer out in the areas where the atrophy is. The younger you are, the more deadly this is because, like, you know, for you and me, hopefully we don't have a lot of brain atrophy at this point, and we can't handle 6 or 7 cc's of blood layering out. They may cause us a mass effect or a midline shift that's very dangerous. Whereas someone who's 80 or 90 may have the extra space, and that's why it's pretty common to see them get subdurals, but it's pretty common to see them survive subdurals, usually with pretty good outcome. And you can have subacute or chronic subdurals too. They don't need to be just acute as well. Bonus, what two bleeds are pathognomonic for non-accidental trauma, aka child abuse?
Guys, we'll give a couple of seconds to. I think you guys are honing in on the right things.
Yeah.
Tricky question. And so the things to think about are, as you guys have kind of honed in on, eyes and brain are the main things. And so essentially what you're worried about is this concept of what we colloquially call shaken baby syndrome. And you have these shearing forces from the acceleration and deceleration on the retinal arteries. And that's why you get the retinal hemorrhage that you're seeing on this fundoscopic image. And then also to tie it back into what Dave did a great job running through of the subdural hematoma in the upper picture there. So again, that kind of crescent. Awesome job, guys. Keep up the great work.
Yeah, very good job. And again, as you know, as sort of mentioned before, it's very sad. These cases don't do well because they don't have the brain space to handle this blood.
Yeah.
Very sad cases.